at first, we have patients present with dryness complaint. And then what you should do is the detailed history and look at the risk factors. And look at the risk factors if anything is modifiable. And that's the first thing we should do. Now, we know very well BCLA clear report, the global consciousness report we have, it does talk about also looking at the dry eye risk factors even before prescribing contact lenses. So when you have detailed history and risk factors, we should be able to differentiate diagnosis between aqueous deficiency and evaporative dry, or maybe mixed, and try to quantify the symptoms. Is it moderate, severe, or mild, or maybe it's just a pre-diarrhea patient. So if I go next, and then we go ahead with some of the tests, which is non-invasive breakup time, staining, and osmolarity. Now, if it's not, then we can just see pain referral, because if they're not correlating well, then we should actually know better with anesthetics, and we should actually go for pain referral. That goes in different directions, and often we refer to ophthalmologists for this. So now, if it's yes, and then we go for subtype, and the subtype is aqueous deficient or evaporative dry. So TR meniscus height, mammography, interferometry, which is an assessment of the lipid layer thickness, and meibomian gland expression will tell us which direction is going. Is meibomian gland dysfunctions and what type? So if it's aqueous deficient, which means TR meniscus height is low, but their meibomian glands, etc., are doing pretty well, then artificial tear is a very good idea to start. More viscous, it stays in eye more longer, and of course non-preserved, because they will not cause essential more inflammation in the eye. And currently we know that we should wait for a month and see if the treatment is working. We should not wait for many months and ask the patients to come after 6 months. If it's not working for a month and patient is still complaining of more of this, we should go ahead with punctum plugs, because we need to preserve the tear. The tear is good and tear is not toxic, hopefully, and we can look at them. And what are the options we have? We have scleral lens, we have serum and amnions, and we have secretagogues. It depends which where you practice, which one is readily available, or perhaps you can actually co-manage with someone who does prescribe and manage this type of patients. Now, when I go for other way, which if we think it's evaporative, which means TR meniscus height is okay, but then as a meibomian glands dysfunctions and lipid layer is compromised, then we try to look at the treatment such as artificial tear. And of course, it's a more of lipid based, because when it's complement to the lipid, the tear is more stable. It's a liposomal non-preserved spray drops. We have warm compress to help the more meibum, the lipid, to come out and protect the tear, and lead hygiene, blepharitis, and demodex, etc., which is more of a management of the leads, which we quite often do it as a first-hand treatment and management. Now, again, we know with a recent study that we should wait for a month and see what happened. We should not wait for very long and continue to have symptoms for the patient. If it's still not working, we need to look at in-office lead management and see how the patient is doing lead hygiene, blepharitis, or maybe ask the patients to come regularly to have lead cleaning and see if the signs and symptoms should be better. The other options are going for IPAO, depends on which part of the world you practice, and over next 2 to 3 months, and IPL does pretty well job in terms of keeping the symptoms and sign low for a while. And if it's still not working, or it's partially working, it next need to go for anti-inflammatory antibiotics, depends what type of disease and it's way progressing, so I need to co-manage. I think this is overall management of dry eye and currently evidence we have. At the top also we have advised disease and environment diet. These are modifications you do at the top when you take history and risk factors. You have subtype, what type of disease it is, a dry eye, and advise the disease, environment, and diet. So with this, where our biomarker sits, and our biomarker sits right at the center, where actually trying to differentiate aqueous deficient or evaporative type, but also biomarkers can sit easily at the detailed history, risk factors, and continue to do diagnose. And perhaps at this point, if the patient is pre-dry eye patient, you may be able to act, or you should be able to actually foresee if the patient will land up to having dry eye in future. And that you start to have the advice, disease, environment, and diet maintained, and to slow or lag or delay the progression. I think that's all for me today. So it could be mixed, and when I say mixed, you need to really put them together with artificial tears, viscous and liposomal sprays. But it depends, again, the biomarkers and testings should be able to help you and quantify what directions.